I'm a medical social worker in the community. I work for Hospice in Santa Cruz County, and I manage the transitions program there. It's a program for someone with a serious illness, but who isn't on hospice yet. I'm also a volunteer with the Alzheimer's Association, which is why I'm here today. I sit on the program committee for the association, and I've been a volunteer on and off since 1989 when my mom started doing some strange things, and suddenly we realized that it wasn't just stress and she had Alzheimer's disease. And a friend had suggested I call the association, and I called the Alzheimer's Association, and it changed my life. And today I'm eternally grateful to the association for the support that they provided and continue to provide. I'm so grateful for their presence in our community. In those early days while I was caring for my mom, I was attending a support group, and I don't know, how many of you were attending support group at Alzheimer's Association? So thank you to all of you. You weren't there in 1989, but it was such a help to me, and I encourage it for anyone that is caring for a loved one with Alzheimer's disease. And I want to also thank the association for allowing us to have this panel today. There's not a lot of people who want to talk about late stage of anything, and we're so fortunate to have these three panelists today to talk about just that, to talk about what it looks like with late stage dementia. And I'll introduce them in just a minute. I want to tell you what we're going to be doing today, and it's our hope that you'll leave here and have a better understanding of what late stages of dementia looks like. Some of you may already be seeing that in your loved ones or the people that you care for, but we'll be talking about that today. We'll talk about ways to get an understanding as to emotional, physical, and spiritual support, not just for the person with dementia, but also for their loved ones and their caregivers. We hope that you'll have an increased awareness of some of the options that are available to families when they're caring for somebody in late stage, and hospice, for instance, is well represented at this table, and other options that are available. And so we'll be talking about mechanical life supports versus comfort care and the kind of support that you might get through a hospice. We also hope that you're going to learn meaningful ways to interact and spend time with your loved one or with a loved one that has dementia. So with that, I'd like to introduce our panelists, and it really is my privilege. I do hospice care. I so much appreciate anybody that has the courage to do this work or has the heart and the courage to open up to hear about this work. So thank you so much for that. And each of the people that are sitting at this table bring with them just a total commitment to compassionate and high-quality care for people with late stages of any disease, but particularly with dementia, and a high regard for the caregivers, for the loved ones of their patients. So with that, I first want to introduce Dr. Vanessa Lill. And Dr. Lill is the Chief Medical Director in Hospice of Santa Cruz County. She has a strong commitment to whole person care and has been consistent with that through her years as a doctor. She recently completed the Med Institute End-of-Life Care Practitioner Program. It's a 9-month program for people that are interested in learning about mindfulness and compassion in end-of-life. And it's just consistent with the commitment that she has for this work. And so we're very, very fortunate to have her today. Dr. Grace Lorenzen is a board-certified family physician with over 20 years in Santa Cruz County. Again, we're so lucky to have her in our community. She is the founder and president of Santa Cruz County's first concierge medical practice, called Lorenzen Personal Physicians, and I added this piece just like it's in a recognition that not all patients are able to get to the doctor's office. And in her practice, she meets people wherever home is for them. So thank you so much for that. And then finally, Forbes Ellis is an MFT, American Family Therapist, and a bereavement counselor for Heartland Hospice. who has extensive experience in working with loss, grief, counseling people. He has a private practice in the community, and currently he's providing a training in the community called How to Care for the Caregiver, which is being offered to various agencies, including the Alzheimer's Association and residential care facilities and skilled nursing facilities in the county. Again, he has a private practice in the community specializing in grief and loss. So please join me in welcoming our three panelists. So what I'm going to do is I'm going to ask some questions. I'm kind of going to ask a group of questions and then ask them if they could just discuss it, right? Rather than here's a question, here's an answer. Just to discuss it. And then when we're all done, we're going to open it up for questioning and answers from all of you. And I really encourage you not to be shy. What an opportunity to have this much experience and compassion this afternoon. So do please feel free to ask questions. So here's the first series of questions. What are the signs and symptoms of late-stage dementia? How do you define late-stage dementia? What does that look like? What's the average duration? How long might late-stage dementia last? Is there a rationale for treating or not treating some of the symptoms, like urinary tract infections, pneumonia, other infections, not eating, not drinking, some of those things that may be fairly common when somebody has late-stage dementia? And can you discuss the pros and cons of mechanical life supports like feeding tubes? Is there a need to modify medications during late-stage dementia? And when is it time to call hospice? And what can hospice actually do for somebody with late-stage dementia? So with that, I'll turn it over to the panelists. Who'd like to start? You want to use the mic.
So I will start, and I think one of the greatest challenges both for caregivers and physicians and hospice is how difficult it is to know exactly how long for an individual person late-stage dementia will be. There are statistics out there, and in front of me I have here anywhere within 6 years could be a long term, and then late-stage dementia, what it looks like to me is when someone is not speaking very much. We usually think about less than 6 words, not ambulatory well, with assistance, incontinence, and other examples as the stage progresses. And so those are the type of things we're looking for also when someone might be considered appropriate for hospice. So I'll get to that part now about what hospice can offer. And hospice is a collection of an interdisciplinary care team that will care for patients and their families as the unit of care with a plan of care driven by the patient and their family's goals. And so what we can do is in hospice is you have chaplaincy, social work, nursing, physician, the attending physician that the patient already has. We have hospice aides that can do some personal care on an interim basis, and volunteers. So it's attention to my, you heard Shirley mention my whole person care, attention in medicine, and what I love about hospice is that really, in my mind, is a true interdisciplinary whole person approach. And so one of the things that hospice can do is to help guide through some of those difficult decisions about particular interventions and what may or may not be appropriate for an individual based on their goals of care and their disease severity. I know that my colleagues.
So, yeah, as Dr. Little said, the duration can be anywhere from a few months, and I think the way to think about it is that when a person is no longer really able to communicate and really able to take care of themselves, those activities of daily living, bathing, eating, they're no longer able to do that. That, I think, would be what most people would say would be the beginning of late stage. And and the duration, as I said, a few months to up to 3, 6, 4 years is what they say, although it has lasted as long as 6. But you have to realize that at that stage, not just the outside symptoms such as not eating, but internally there are things that are changing as well. People are beginning to just slow down. I kind of, I must say, it kind of reminds me, I'm not a Star Trekkie, but I used to watch a lot of Star Trek when I was a kid, and there were these scenes where the Enterprise was like powering down. That's kind of what I see. People are just sort of powering down. Things are starting to get less active. And the decision to treat or not treat, I think, is really one that's based on symptoms, really. I mean, is the person uncomfortable? And these are hard decisions to make, I think, but these are hopefully questions that have begun to be discussed when the dementia was in its mild to moderate stage. It's hard to sometimes get to the place one needs to get to if you're starting to just have these discussions when a person is this far down the line. But the issues are really about what is the comfort level of the person who you're caring for. So the question about whether or not to treat really is about what do you believe is that person would want, and then working from that plan of care. And finally, there's this issue of pros and cons of feeding tubes. And I'll tell you, having been in New York in the fall, I went to a palliative care conference there. Something like 75% of people with severe dementia have feeding tubes. It's a scary thought. It's driven culturally. I mean, people there believe, a lot of the doctors there believe that you're doing wrong if you don't give someone, quote, feeding. The reason I make the point about the powering down is that there comes a point where what you're doing is sustaining a body that is no longer housing the person, and the question really becomes, is that what that person would want? And so, at least in our community, I think people have begun to recognize the fact that you're not taking care of the person by putting them on and putting an artificial feeding. That all you're really doing, in some senses, is taking care of the family, but you're not taking care of that person. So it's difficult to make those decisions, but if you take it I think in the holistic context that Dr. Little was talking about, and realize that this is not just a series of individual problems. It's not like a person stops eating because of an individual problem. This is a holistic issue that's taking place within this body. Then I think it becomes easier to make those kinds of decisions.
So another reason to accept hospice during this time is that we offer grief support after someone has passed away, and the grief associated with Alzheimer's is referred to as anticipatory grief when the illness lasts for a long time, and that's a phrase that became more popular when the AIDS epidemic became more mainstream and talked about. So that presents different dynamics for people. Often you mourn the loss of someone long before they actually die. So when they do die, you may not have the same degree of strong feelings because you've already done a lot of process work before then. Oftentimes people will feel guilty, thinking, I should be grieving more. What's wrong with me? Is this okay? And so in hospice, we support people for up to 13 months after someone passes away. With those types of situations with grief, etc. And one of the models of grief that I particularly like is working with people around how to let grief break your heart open as opposed to grief breaking your heart into pieces. And it's okay to fall apart. It's okay to allow your heart to break into pieces too. There's a value in that. And there's also a way in which we work with people to utilize grief to honor the connection that they had with someone. If they didn't have that connection, they wouldn't be grieving in that kind of a way. So there's different ways we can work with grief. Sometimes the grief is complicated, where the relationship the person had with the patient wasn't really all that great. And so someone is grieving what they never had. with their mom, their dad, etc. And that can bring up more feelings of guilt, etc. So there are dynamic ways we work with the dynamics of grief, and that's another reason to accept hospice, because you do have access to more services. And just to dovetail a little bit on what was said, the social work function in particular, which I've also served as a social worker in hospice, really allows you to plan as much as possible things like the will, the power of attorney, advanced healthcare directives, do not resuscitate orders, things that if the patient is still able to, and if they haven't already, can go a long way to provide a security blanket in those end stages, which can be really important.
Thank you all. And I just want to make a pitch. April 16th is National Advanced Healthcare Directive Day. And for any of you that don't have an advanced healthcare directive, or your loved ones that can complete their own advanced healthcare directive but haven't, I really encourage you to look for one of the workshops that's going to be happening around the county. We've got 3 or 4 different ones going on.
Is that different than the pulse?
Yeah, it is different. This woman asked about the physician's order for life-sustaining treatment. It is different than a pulse, and both documents are good to have. Okay, so the next set of questions. Do we know anything about what the individual with dementia may be aware of in their surroundings? Are there any clues as to what to look for to determine if the individual is aware of what's happening or aware of who we are? In late stages, when the individual with dementia may be unable to communicate in any way, do you have any suggestions to help families feel connected with their loved one?
So I think that people, at least my experience, is that people often go into their stages of dementia much the way they lived. In other words, someone who is quiet speaking is not someone who spends a lot of time talking. It's not going to all of a sudden become talkative. So I think the main thing to do is to try to be cognizant of nonverbal communication. And the reality is that most of us are doing this all the time. I mean, someone says something to you and it doesn't jive with what their body language is saying, you know that immediately. I think, so while it sounds like it's very technical, something like 75% of all communication is done between people normally is nonverbal. And so I think that we don't really know. And it's hard to, again, I think the one thing to take home is it's very difficult to generalize. Because these stages are it's not sliding down in a very linear path. People are more likely to go up and down. There may be one day or a week where a person won't say a word, and you'll walk in one day and they'll say, "How are you doing?" And you're like, "Whoa, this is amazing." And I would say that because of that, we can't really generalize and say this is what to expect. This is what this person is understanding or knowing. But in the same way that you would not talk about someone in front, who does not have dementia in front of somebody else. It's the same sort of thing. I think recognizing the fact that since we don't know, we make the assumption that there is some knowledge of what's going on there, and I think treat a person as respectfully as we possibly can in that situation. And then in terms of I think feeling connected is sometimes hard. That connection, there are moments when that connection feels very tight, where you see a glimpse, and you sometimes need to hold on to that glimpse for weeks because you may not see it again for a long time. I think connection requires a sense of your own self, and I spent a lot of time yesterday talking about a patient of mine whose father is going through this. And I think the thing I would underscore is that you have to have your own reserve. It is difficult to connect with when you're running on empty. it's difficult to recognize the moments when you can have that nonverbal communication. If you are frustrated, frazzled, angry, and so I think that taking care of yourself first allows for those connections, however long they may be, to actually happen.
I think it's hard to know how much another person knows with everyone, and nobody taught me this in medical school, but I'm learning in my experience to rely on my intuition. And I think that is a way to trust your intuition and how much someone is understanding. And I asked my hospice team this morning what tools they use to help build a relationship and connection with someone who's not verbal. And they mentioned things like music and singing and pictures, and a chaplain brings in nature objects to hold things with tactile differences. But I think one thing that really struck me was with every person to build on their past, to look around a room and to talk to families and to bring to that individual what might be, what was meaningful to them and what is likely meaningful to them now. And to also sometimes notice our own discomfort, and I think this is what you were also talking about, that a barrier to connection can be our own fatigue and anger and frustration, and that's okay to have it be there too, but to notice it and not let it be the barrier to connection.
Yeah, I think that the way we connect with our loved ones, or a caregiver can connect with a patient, is by first staying connected with ourselves. If we're running around multitasking, doing a lot of things at once, there's no way that we can fully connect with the patient or our loved one. So first, self-care, as has been said, is so important. I particularly like the work of John Kabat-Zinn and the mindfulness-based stress reduction techniques. The way of not giving into the anxiety of what's going to happen in the future or dwelling on the past, but as much as you can to try to stay present in the moment without allowing your monkey mind to get the better of you, which I say with compassion because I believe we all have that monkey mind. And so we probably don't have a lot of time to talk about all of those techniques, but I think that's a wonderful way to be present, and then, as was said as well, we attune to the patient, and so the latest attachment research on child development says that attunement and the way that a parent connects with a child, mostly non-verbally, is the strongest indicator towards a healthy attachment, a secure attachment, as opposed to an insecure or chaotic attachment. So if a patient is in bed and is already vulnerable, and you're really using your eye contact, your tone of voice, your proximity to the patient, sense of touch, a reassuring, calm way of being with the patient, I really believe that that goes a long way. And I do these trainings also in skilled nursing facilities where patients are doing what all the time? Pushing a button, right? And so what I try to tell people is there's a way to potentially reduce that feeling of neediness in the patient by offering 5 minutes even of focused presence goes a lot farther than 15 minutes of sort of half-baked attention. So I think that that's something to consider. I think the environment is super important with Alzheimer's patients. They're often more sensitive to light, to sound, to the ways that you can use feng shui or other techniques to work with the environment that will allow a patient to be more comfortable and potentially more open themselves to connecting with you, which will also help that connection. A nice tangible way also, and this goes more for caregivers who are not part of the family, is to create a photo album. So often Alzheimer's patients are viewed as bodies that need to be taken care of as opposed to whole people who've had full lives. So I think a photo album that you can share with caregivers will allow them to really develop more empathy for the patient, seeing the history of who they've been in their life, not just who they are, who they appear to be now. And that will go a long way towards the quality of care that someone receives, because that caregiver is now more indoctrinated into the life of that person will have more compassion for where they're at now. And I think that's really one of the keys to getting caregivers on board with who this person is, not just how they appear to be now. So.
Thank you. The next set of questions are really for caregivers and loved ones. When is it time to consider extra help in the home or even moving out of the home and into a long-term care setting such as assisted living or skilled nursing facility? And can you address the myths and the judgments regarding out-of-home care settings? And can you discuss the various levels of care someone with late-stage dementia might need?
So, in my experience, the question really comes down to what are the realistic, what's the realistic time and energy that the primary caregiver has, and is there a way? It's a financial question. Can you afford to bring people into the house? It's also a question of what kinds of care does this person need. I mean, when you're talking about late stage, you're still talking about someone who is probably needs almost 24-hour care. They're not able to, they're incontinent, so they're going to need to be changed often. But again, depending upon the other medical problems, there may be a lot of medications, there may be a lot of other needs. And so I think it's almost unrealistic to talk about assisted living facilities. By definition, assisted living facilities require that person, unless they're there with a hospice waiver, that facility is really unable to take care, to give the level of care that's necessary. So then you're talking about a nursing home. And I think, I've had patients in all the local nursing homes over the years. And I think that the quality of the nursing home is less about the place and more about the staff. And also more about how they connect to you as well as to your loved one. There have been patients who have been in places that, people say, oh, that's not such a great place. But the staff, for whatever reason, takes a liking. And the person is seen as a person. And that kind of connection, you can't always figure out how that happens. Maybe your loved one reminds them of somebody they knew. But I don't think that it's a cop-out, as some people have said to me. Am I abandoning my family member if I just can't take care of them anymore and they need to go into a skilled nursing facility? No. I think the main thing is having the honesty with yourself to recognize the fact that this is not a sprint, it's a marathon, and you have no idea where the finish line is. And so if in your heart of hearts you look around and you realize, I cannot do this, and I cannot muster the caregivers, I think having a person in a skilled nursing facility and then being an active part of their lives within that facility is very important and very helpful. But I think it's just another. It's less about where and more about how. How is this person being taken care of? And how are you feeling? If you can go there knowing that you've gotten a decent night's sleep because you're not up all night because the person is moaning or calling out to you every night, that's going to be better than as Forbes said, sort of dragging yourself in and saying, now what is it? So I think that it's a viable option.
Well, I think that I was reading a study, and it said that 70% of people with Alzheimer's live at home, and the amount of time that caregivers spend taking care of their loved one ranges from 69 to 117 hours per week. So again, I think it's important to be realistic, to do the best you can, and also to forgive yourself if you're having negative feelings about having to utilize a home to take care of your loved one. There are a lot of us who are also part of the sandwich generation where we're raising children and also taking care of a parent who may have Alzheimer's or dementia. So I would say that in that case, the hours in that study might be even greater. So this is a really tough question and thing to talk about. 100 years ago it was very different. Everybody tended to live together, and now we're all splintered in different parts of the country, and there are different parameters. Oftentimes, someone will move a parent from the East Coast to come out here, and the person with Alzheimer's or just needing care in a facility will go through all kinds of loss just in that move, in and of itself. So there's a lot of new modern considerations around homes and nursing homes, and there's no easy answer either. I think it's like raising children. We all have certain family structures, needs, and realities that we work within, and we have to do our best.
I just want to add a couple of things. First of all, Dr. Lorenzen mentioned assisted living, and maybe for somebody in late-stage dementia, assisted living wouldn't necessarily be an option. She mentioned that term waiver. And if you've got a loved one that's in an assisted living facility, a residential care facility, and as they're getting closer to the end of life, and if hospice is a consideration for you, assisted living can apply to the state for what's called a waiver, and the waiver allows them to have people there that are significantly declined, but they can stay in the assisted living as long as they're on hospice. So if you have a loved one that's in an assisted living and you're hoping for your loved one to remain there through the end of their life, I would check with the assisted living facility to see if they have a waiver. And I would have to say that most assisted living facilities in this county have a waiver for a certain number of their residents. So that's something to check out. The other thing I wanted to just mention from my own personal experience and also professional is that this caregiving stuff isn't a one-person job. And so I think that's an important thing to know going into it. It's not something that one person can do alone. And so all of the considerations about skilled nursing facilities, assisted living, hiring caregivers, we've got wonderful of all three of those. And it's just not a one-person job. So I wanted to just add that. Next set of questions. Dementia has been described as a long goodbye. Can you describe what anticipatory grief is and the impact of witnessing great and gradual loss over the course of the illness, which for some can be a really long time? I mean, my mom was 11 years, and I've met people today whose loved ones have been even longer than that. Families have a tendency to minimize this grief, or they're so busy providing or managing care that they aren't even aware of it. And I know we've talked a little bit about that already, but I wonder if there's anything else to add. And maybe, Forbes, if you can explain what anticipatory grief is.
Okay. So, I think I mentioned a little bit already, anticipatory grief being where we know that someone has an illness that, at least at this present moment, doesn't have a cure. So we start to grieve the loss of that person before they've actually died. I think that one thing to be aware of is that, obviously this is stressful. This creates a crisis in the family system. And we all react to crisis differently. We all relate to death and dying and illness differently. So I think that the more people can do to confront their own issues around mortality and illness, the better that will be for you to connect with your patient, your loved one. I always tell people that when they get a terminal cancer diagnosis or a serious illness, they'll be surprised that there are people that they expected would show up who don't. In fact, they disappear oftentimes. And there'll be other people who they had no idea would show up who are bringing them dinner every night. So it has more to do, I think, with people's own relationship with death and dying and illness as opposed to what happens is the patient will take it obviously very personally. Where's my best friend? And this is, I'm speaking generally, of course, but this happens with some consistency. So I think that, familiarizing yourself with the stages of grief, there's so many books. Obviously, the grandmother of grief is Elizabeth Kubler-Ross, and there are many ways to familiarize yourself with what you may go through. There's no right or wrong way to grieve, and grief can take mental, physical, emotional, spiritual forms. So it's really individual how that may manifest. But one thing is for sure, that prolonged stress will create potential, anxiety and distress, depression perhaps, so that it's really important to, I'll go back to the mindfulness-based stress reduction. There have been studies, evidence-based studies, that utilizing these types of techniques will decrease your anxiety, your psychological distress, depression, and also increase your empathy, which I think is an interesting measure for a study. And again, goes back to our ability to connect with that patient. If we can really put ourselves in a person's shoes, we might understand what we might want ourselves and then be able to provide it for that patient. So, grief can either separate us from our own experience and from the client, or it can bring us closer to ourselves and the client. It's all about our own personal relationship to it. And again, get support if you need it. There's a lot of support available in this county. The Alzheimer's Association is an amazing support. Hospice of Santa Cruz, Heartland Hospice, and others. So.
Thank you. When I think about the long goodbye, and I know you all know what I'm talking about, it's that last week they knew how to drink out of a straw, and this week they've forgotten that. Or last week they could stand up and walk, and this week they can't. And last week they knew my name, and this week they don't. Those are the sadnesses that we experience through the process of dementia, and that make up that long goodbye.
I think the only other thing I would add is that different members of families grieve differently. And it can be a source of real friction because people are at different stages in the same family. And it doesn't necessarily mean that the person who's most close to the family member, to the person who has dementia, is in the quote right stage. There's no right stage, but I want to point out that a couple of things that happen with families. Number one, people don't change personalities just because they're grieving. And so, the person who you didn't get along with very well, who happens to be your sister from, Minnetonka, is not going to necessarily rise to the occasion. And that creates a lot of stress. And so I think that recognizing that people will be who they are along, in terms of grief and actually even more so with the stress is important. And we harken back to the idea that when you have enough in your tank, your reserve, you can look over and see, my sister is grieving. She may be angry. She may be calling me every week about why aren't you getting mom out of bed? I have a patient of mine whose sister's, why aren't you getting mom out of bed? You should get mom out of bed every day. And it's her anxiety that's there. And your ability to step back and recognize that that's what's going on and have a sense of compassion for her is going to go a long way, because that tension will still be felt. It's a nonverbal communication. That tension can be felt by your loved one with dementia. So I think it's just important to recognize that although it would be lovely if families could find a way to do it together, the reality is grieving, like everything else human, is pretty messy.
And also that there's grief around death, and grief around functional loss, and grief around all the different aspects of the relationship that aren't how they used to be and aren't how you imagine that they would be at this particular time in the life that you're living. And one of I find sadness often in working with families where someone made a promise once that they would never let their mother go to a nursing home, and it's a promise that is breaking them down physically and emotionally and is becoming really hard to keep. And what we do in hospice is to try to support them towards self-forgiveness if it just can't be how they once made a promise at a time that was very different and without knowing what the future was going to hold.
Given the decisions likely needed to be made in late-stage dementia, and we've talked about some of those today, do you have any suggestions for the family in developing skills for working with each other? And I know Dr. Lorenzen just talked about that. I mean, some of us probably wish we had families who were grieving and calling every day, because some of us have family members that we never hear from. But I wonder if anyone here has any suggestions on how to work as a family.
Well, Skype is not a bad way. I mean, I'm serious. I mean, I think that we have these tools that even 10 years ago we didn't have for communication. Email, please remember that email is tone deaf. Before you hit the send button, I have a friend of mine who we would joke that we kind of wanted to put, when she hit the send button, something that said, "Are you sure?" Because, in that stressful situation, you may say something, or that's in print and will be not only in print, it's not like it's heard, it's now forwarded to everybody in the universe. So, but I do think that opening whatever lines of communication, whether it be Skype, whether it be email, whether it be phone calls, and also not being afraid to have a counselor sit down as a group. I mean, you can now do conference calls pretty easily, and have someone sit and mediate, especially for critical decisions that are having to be made, and you want to make sure that people hear and feel as if they're being heard. Having someone there who has a professional ability to not be in the middle, but help to facilitate that discussion. It can happen anywhere now. I mean, if you have a phone, you have that ability. And I would encourage people to think outside of the usual ways of communication with their families, in order to be able to sometimes even just keep people on the same page. This is where sometimes journaling is certainly, or having I know people often have blogs for family members with cancer. There's no reason not to have one with someone who is in their end stage with dementia. It keeps people in the loop. And that communication, that knowledge of what's going on, allows people to feel as if they can be empathetic and may even come in and step in for respite care or something like that.
Well, I really like family systems work, and in family systems work, the parents are at the top of the hierarchy, and then the children. With this illness, the hierarchy flips upside down. The parent becomes more like a child. They say we're twice a child and once an adult in life, when we're unable to care for ourselves towards the end, like a child. So that can cause a lot of chaos and disorganization, especially when there are multiple siblings in a family. Somebody needs to and is more inclined to be in charge. And someone else might not like that. And they might not have liked that since they were 5 years old. So that can bring up some interesting dynamics. And I think, getting support, counseling can be really important. And that's another thing that hospice offers. Lots of eyes and ears through the social workers, the nurses, the chaplains. We work as an interdisciplinary team to provide, psychosocial, emotional, physical, spiritual support. So it's very holistic, it's very comprehensive support. Education is really important. A lot of people don't understand that Alzheimer's is not just about losing your memory, but it's also about losing gross motor functioning as well. Which creates a whole other reality for people to deal with. A lot of people don't understand they're going to have to child-proof their home. And child-proofing the home, by the way, shows a much greater success rate for keeping people at home longer. So any way you can avoid those kinds of accidents that happen, etc., by child-proofing often increase the longevity for someone to be able to stay at home. And again, it's not a one-person job with support, with hospice, with whatever support you can get. So families are as unique as thumbprints. They're all different, and so the dynamics are endless, which is part of my fascination with my work, and also part of the challenge of where to intervene and how to affect change in the family in a positive way.
I guess the only thing I would add is to not be afraid to ask your family members for what you need from them. I think sometimes people feel frustrated that other people just don't innately know what they need, and often if you give people clear direction, they can step up sometimes.
So they can't necessarily read our minds. So are there any other last minute thoughts or words of wisdom that any of you might want to share that's outside of the scope of the questions that we asked? We are going to open it up for questions and answers from the audience, but I wonder if there's anything else any of you want to add.
I guess I would say that when I think back about over the number of years now that I've taken care of older patients who are dying, that are with dementia or other end-stage problems, there can be laughing. There can sometimes be these moments where the person just does something that makes you laugh. That just harkens back to who they were 30 years ago. And I think, it sounds very like repetitive to say, take care of yourself. You'll miss those miracles if you're too tired. You'll miss those miracles if you're just too, the old hungry, angry, lonely, or tired. If you have any of those, or more than two of those, it's just going to be too hard for you to see them. And they will happen. I mean, it's a long period of time, and there's a lot of loss. But it's a lot different than actually taking care of a child, in the sense that this person also has a history with you, has been around a long time, and you know their quirks, for good or for bad, and so you know the things that might make them smile, and when you see that smile, take a moment to really take it in. I would underscore John's Kabat-Zinn wrote there's two books that I know of that I have read and think are very good. One is Full Catastrophe Living, and the other is Wherever You Go, There You Are, which I always think is very cool. It's like, okay, I guess I'm taking myself with me. So, because sometimes you're not. Sometimes you're going, and you're going, and the rest of you saying, where are you going? So I do think, for me at least, it's what keeps me working in this area and wanting to do it is not only just supporting family members and the patient, but sitting there and just seeing that glimpse, and seeing families interact and recognize the fact that this person does have this very long history.
My bias is really to focus on supporting the caregiver, because I feel like the trickle-down effect of that is to support the patient. So one of the studies that I like best says that caregiver longevity is ensured by making sure that you reframe your day by saying, I did the best that I could today. And we live in a culture that's very focused on perfection and caffeination and sterility, and this can get messy. Caregiving can get messy, and if you're in the sandwich generation and you have kids and you have a dog and a cat and you have your mortgage and on, it's easy to get distracted. And so we have to try not to beat ourselves up, and that's a huge challenge, I think, for everybody. So simply reframing your day when you're finally hit the pillow and say, it wasn't perfect, but I did my best. And the service that you're offering to this person is really, for some people, a very spiritual practice as well. And I think that the other thing about longevity is if you have any kind of spiritual support, that also was cited in this study as being a very high determiner of your longevity as a caregiver. There's a Rumi quote that I really like that goes along with self-care, and it says, he says, 10 minutes alone in your room each morning is worth all the gold in the world. So when you can take that time in the morning, especially to be in nature or do whatever you feel inclined to do that has that maybe a spiritual feeling or just a good feeling, we'll say, then that kind of tunes you for the day. It kind of sets your radio dial to maybe a place that will sustain you through the day, whereas otherwise you might have had a harder time. So,
I'm excited to hear your questions and comments, because I know that there must be tremendous wisdom and experience in the faces I see in front of us.
I just want to again make a pitch. The support groups at the Alzheimer's Association were such a support for me, and hearing, as Dr. Little just said, hearing the wealth of the people in the group, I learned so much. I mean, there was this guy, John, whose wife Mary had Alzheimer's disease 20 years ago, and I swear I quote this guy once or twice a month. Something he shared at the support group. So really make a pitch for the support groups, and also the Alzheimer's Association just in general is a wonderful support for us. And we're so lucky in this county to have so many resources available to us. So if you're a loved one, a caregiver, the Alzheimer's Association is a great place to go. If you're a professional, you probably know where the resources are. Alzheimer's Association is a great place for the professionals as well. So with that, I want to open it up for any questions and answers. And so now's the time to ask that question that you've always wanted to be able to ask someone, but maybe didn't know who to ask.
Can I have a mic for the Q&A?
Thank you so much.
Hi, my name is Renee, and I've lost 3 family members to Huntington's disease, and I just spent the last year and a half caring for my brother at home as he died from Huntington's. Meanwhile, my mother was diagnosed with Alzheimer's, which she's had about 8 years now. And since he passed on March 18th, my mother will not let me out of her sight. She calls my name, it seems like every 6 minutes. And I want to be there for her. I had 3 caregivers for my brother before he passed. I've kept one, but I got a text from her at lunch that stated my mom wants to know when I'm going to be home. And I have yet to get a break, and I've yet to grieve my brother. And I'm thoroughly exhausted, so I'm just wondering if you have any answers for that.
That is hard. I think, let me ask you a question. When you are there with her, does she recognize that you're there?
Yes.
And when you are gone, is it difficult for someone to take care of her?
Yes. She wants it to be me.
I know that, but that wasn't my question. Is it difficult for the person to take care of her?
They're able to bathe her and take her on errands. They're able to bathe her and help her. She's incontinent. But she's defiant. She doesn't want to do anything with them. She doesn't want to talk to them. She wants it to be me.
Mm-hmm. So, I think that again, this is sort of, I'm going to preface it by saying this is my particular bent on it. I think that you have to sometimes separate out wants versus needs. and recognize the fact that if she is in a safe environment, if she is getting her needs taken care of, then you are doing a very good job. You are doing an excellent job. To the extent that you can factor in, schedule in, I'm going to go away this evening. I'm going to a movie this evening. I'm going overnight somewhere. Friends, hotel, somewhere. You are not abandoning her because she says she wants you. You would be abandoning her if she needed you. And that's different. And so, again, this is a long... She is actually... doesn't sound like she's in late stage.
She's in mid-stage.
She's in mid-stage, yeah. So this is the sprint. I mean, this is a marathon. And you need to have that time to grieve your brother. You also need to have the time to get some sleep and to get some rest. So as as someone who takes care of a lot of patients and families, I would say you are no good to her if you are not able to have that reserve. You are doing a good job. You're doing a great job. You've got the help there. So I would simply say, all right, this is what I need, and that's not a bad thing to do.
Any other questions?
Thank you.
Yes. Oh, can you hold on for the mic?
Do they just raise their hand? I'll come to them.
Will you raise your hand?
I'd like to ask, or maybe get some clarification on what your ideas or what there is available to help the people not have feeding tubes, because you stated there's about 75% of late-stage Alzheimer's patients that have them, but we also know that they have difficulty swallowing at that time. And what is the option if they don't get a feeding tube? How are they going to get nutrition? You just can't take nutrition away from them when they're still, even if they're in a late stage, unless they're absolutely, unconscious and dying. So I didn't know at what point you're seeing that they can't have a feeding tube or it's not suggested anymore. That's a predicament for me to try and figure out.
So,
What I was saying was that in contrast to here, New York, when I went to New York, it was the cultural shift was that they had people had feeding tubes. That's all. I was not advocating it by any stretch of the imagination.
and I think a decision whether or not to pursue a feeding tube is going to be a very individual one, and I don't think anyone up here would want to tell you or what would be right for your loved one. But what I think is important is for people to know that that's a choice, that they have the opportunity to make that choice and know what alternatives might be. I know that feeding tubes in patients with end-stage dementia are much more common in certain areas of the country in facilities, because and a hypothesis about that is that it takes a lot of time to feed someone who requires one-to-one assistance to eat. And with dietary modifications in terms of consistency of food. So that is one other solution is one-to-one assistance, and that's a very timely process at times. And but another alternative is to monitor, to assess whether a person is interested in eating. And sometimes, as death becomes closer and as diseases become more severe, and it may be a natural progression of the disease itself, to lose interest in eating. And that's something we see across all diagnoses in hospice. And does that answer your question?
Well, yes, thank you. Do you feel, though, that sometimes it's a protective mechanism to give them that feeding tube because they could choke on the food because they're not swallowing as well when they get into the late stages? So it's actually, protection for them, just like if they're sitting in a chair to protect them so they don't get up and fall down and keep them safe. So I was a little confused if they're using the feeding tube, not so much to sustain or their appetite, but to protect them from choking or aspiration.
So I think you have to look at aspiration, at swallowing, as a motor function that is going away in the same way that cognition is going away, and in the same way that other facilities, the ability to hold urine, the fecal incontinence. It's a process. It's a package. So while you can give nutrition to the body, you're not really. The fact that the person is unable to swallow is a function of the whole disease process. It's not like someone who can't swallow because they've had a surgical procedure, and so you expect for them to be able to swallow at some point. I mean, I'm not saying that there's never a reason to ever have a feeding tube, but in end-stage dementia, what you're seeing is a total body decline. And in the context of that total body decline, the inability to swallow, the lack of interest in food in general, the sometimes shutting down of the mouth and closing the mouth is part of the disease process. And in the same way that you wouldn't force someone to stand up and walk, you need to stand up, even if they can't. I sort of see in the same way, if a person is no longer able to swallow, you can still make them comfortable, but this is a stage of the disease. So that's just another way to look at it. It doesn't. I think I really underscore Dr. Little. These are hard decisions to make. These are decisions that you also have to figure out what the person might want. But I think it's the issue that you have a choice one way or another to think about it.
And also to know that, just medically speaking, that if someone is spending most of their time in bed, that having a feeding tube doesn't decrease the risk of aspiration. You can still aspirate indoors.
I just want to mention, Dr. Lorenzen talked about kind of the mechanical piece of swallowing, but also on hospice I've had patients that could be sitting here talking with us right this minute, and you could hold up their favorite food and they wouldn't be interested. It seems that as people get closer to the end of their life that they just lose that interest. Doesn't matter. It could be strawberry shortcake or chocolate eclair. They just might not be interested in that. And I think about it as like forcing food, forcing nutrition is kind of like swimming upstream. It's difficult for the body.
One of the earliest support group leaders in Santa Cruz County, her husband was in the Veterans Hospital, 3.5 years in a fetal position with a feeding tube. And it just broke her heart. She could not handle that. It was very difficult. No, at that time, the medical directives and stuff was not in place. This happened 30, 35 years ago. And she did not have a choice.
And thank you, Linda, for that reminder, that if your loved one isn't in late stages, right? I mean, if your loved one is able to do an advanced healthcare directive, is able to do a post, is able to have that conversation, then this is a time to go back and look at that document. And what did they say? What did they say? That if their life, if they had some kind of a terminal illness or they weren't expected to live for more than a matter of months, would they want their life prolonged? And what kind of things would they or would they not want? And this is a time to go back and pull those documents out, because people fill those out, they think about it before they do it. And if you don't have one, or if your loved ones don't have one, I really invite you to do that. The other two things I want to mention is that I forgot. I'm sorry, I forgot to bring. The association has a pamphlet on these kind of hard decisions, And if you give me your name and address, I will mail you a copy of it. The other thing is that you can go online, and there's a wonderful little book called Hard Choices for Loving People. And it also talks about some of the kind of decisions that we're talking about right now. And you can read that little booklet online, and it gives you some good information. Yes? Hold on just 1 second.
So I'm reading this for a friend that asked me this morning this question. My mother lost her husband of 71 years this month. She forgets that he died. She called me yesterday saying she had an emergency. Her husband was missing. Should I write the events down where she can see them and read them? It's very difficult because she grieves every day that I have to tell her.
You guys have hard questions. I think my thoughts are, it really depends on probably even a day. I would really try to maybe limit the times I have to share the information again, if it's going to bring on grief again, if it's going to be immediately forgotten. But it sounds like if there are circumstances that she's noticing he's not here and it feels like an emergency, that you're going to have to be truthful.
Yeah, usually another thing that comes up is just, I'd like to let people know that to humor their patients when the patients talk about things that might seem unintelligible to you, or these stories that may have never happened in as far as you recollect. This I would see as a higher level question around how honest should you be with that person. I think that I would really want to know more about the person and their history and their coping styles and strategies. But it sounds like, in general, that this is obviously a source of ongoing distress for this person, which ultimately may not be to their benefit. So, there's no right or wrong answer to this question as far as I'm concerned. Just thinking off the top of my head, you could consider finding a way to finesse a non-answer, a distraction, like you do with little children sometimes. We're about to throw a temper tantrum and you find a way to distract them, and all of a sudden everything's fine again. So that you may have some success with that type of approach, where you lovingly distract them. It depends on their attention span that day, that moment. If they're more lucid, you might have a much harder time, and that might be an instance where you decide to have a heart to heart with them and let them know that actually this person has passed away. If they seem more distracted and less lucid and more distractible, you may decide to try to change the subject or gloss it over. That might not fly on another day. So I think because this is a day-to-day issue, it's going to be different every day. And so, wow, what a challenge. What a challenge. So, again, that's a situation where you can allow that to break your heart open and really empathize with the distress and confusion that this person is going through, and how distressful that must be. And
So I have a patient like that who now lives in an assisted living, well, more like a nursing home area. My strategy is to create a simple narrative. Yes, a series of maybe 3 to 4 sentences about what happened that everybody says, that everybody uses the same terms. Yes, I'm sorry, so-and-so, Jack died. Yes, he died 2 months ago. Yes, we're all very sad that he died. That's why he's not here today. And it sounds like if she's using the phone and she's kind of in the mild to moderate stages, which is actually a very difficult stage because the people really bounce back and forth a lot during those stages. where you're getting the 9/11 gets called for things. I mean, this is where the safety issues become paramount. But one of the things we did do was write it out. We wrote out, and she has it kind of with a picture of her husband and this narrative that is written out. So whenever she asks anybody, any of the sisters say the same thing. And it's taken about a year, but she now understands. She'll say, oh yeah, Jack died, didn't he? Yes, he did die. Oh, okay, that's why he's not here. So it's a lot longer. It is another round of anticipatory grieving that happens. But I happen to think that if a person's that early on in dementia, the distractibility is going to be a little difficult. And that I think, just having, but being more complicated is going to be hard too. So everybody gets the same 3 sentences. And everybody says with the same level of empathy, this is what's going on. And eventually, because there's a context, you can sometimes end up having people remember.
Thank you. We have about 5 more minutes. Any other questions?
Shirley, could you just mention the DPOA workshops and where the information is?
So Cindy is asking if I mentioned earlier about the workshops that are happening around the county this month. There's going to be a workshop, I remember, on the 19th at Dominican Oaks. I don't remember what time. We're going to be at 2 o'clock. Thank you. Anybody else hosting an advanced directive workshop that can tell us the times?
At the VA, at the Monterey Clinic, they're having one on the 16th at 10 to 12, and another one from 2 to 4. Another group is Compassionate Care Alliance out of Monterey County. They're working on getting the whole county advanced directives.
Okay.
In May, they have Caregiver U, which will have an hour section on advanced directives.
And I know if you go to the website for Hospice of Santa Cruz County, there'll be dates and times there for the workshops that are happening in Santa Cruz County this month. So thank you for the reminder.
There are flyers that are
and there's thank you so much. And there's flyers actually at the Hospice of Santa Cruz County booth with workshops that are happening in April around Santa Cruz County. Any other questions? Okay, two more questions and then we're going to need to stop.
Hi, my name is Nikki. I'm an ombudsman. And as ombudsman, we're required to witness advanced health care directives if your loved one is in a skilled nursing facility or an RCFE. And I encourage anyone of any age to get an advanced health care directive. It will state what you want if you're unable to communicate. And just because your loved one has Alzheimer's doesn't mean they can't make those decisions. As long as they can communicate, they're not coerced into signing signing what they want, what a loved one wants. They can still make those decisions for themselves even if they have Alzheimer's. So don't feel like that's an obstacle in getting an advanced health care directive. I think everybody should have one. Let them turn on a dime.
Thank you. One last question.
Disruptive behavior changes tend to, I think, increase at the end stage. And how you handle them with therapy, drugs, things like people are using like marijuana now for feeding and also behavior. Maybe Praxisen versus antidepressant or third, second, first generation, whatever. What's the philosophy now on disruptive behavior and how you're going to handle that?
I say the first line is non-pharmacologic treatment, and the pharmacological treatment is a whole other talk.
Yeah, I agree. I mean, I think disruptive behavior. I think sometimes you can do distractibility there, but I take it as a family system. What is the effect on the family, and I think that you sit down and you go over the options because everything has a problem. I mean, the non-pharmacologic takes time and energy, and it's also I think it's a range. I mean, you may use non-pharmacologic at 4 in the afternoon. You may not want to use it at 2 in the morning. So, but I think it's really important. Every single drug that you use has trade-offs. So I think that it's not one of those things where you just go in and say, okay, we're just going to give this medication. There are trade-offs. You sometimes make the person so drowsy that those glimpses that I talked about before don't happen. So I think it's having an honest discussion with if the person's in hospice with hospice, if the person's not in hospice with their primary care provider, and talking about not only the disruptive behavior when it's happening and how are you coping with it, and then using that to help make the decisions about what to do, recognizing that it's another phase. It's a phase that again may last a long time, but it's another phase.
Sometimes it's hard to avoid that. I mean, when there's guns in the house and power tools, and the guy's, let's say, been a butcher his whole life, literally, and you end up, you can't really place. You end up 51-50 in the guy, and who do you think's going to give him the drugs then? Mental health is. And then, how do you get yourself out of that position?
I think you're actually talking more about mid-stage dementia. And mid-stage dementia, I think, from a caregiving point of view, end-stage dementia has a lot of the anticipatory grief, a lot of the kind of losses. Mid-stage is just frustrating because this person is just all over the map. One moment you can talk with them, and the next moment they're turning on the stove, and you don't know why. They don't remember why they're turning. So they're able to walk, but it's a very frustrating time. I think safety becomes paramount in all of this, and to the extent that you can keep the environment, which I consider non-pharmacologic, by the way. I mean, non-pharmacologic means making the environment safe, so you don't have to use a chemical restriction on that. As opposed to using having their environment safe. So that's what I would say, is that you try to make the environment as safe as possible, and then only then will you need to use the chemical handcuffs.
Yeah, we tend to think about falls and cords and rugs, and no one sells the power tools and guns though. I mean, they're still there.
So we need to stop now, and I'm so sorry. Thank you all for your questions, and thank you for participating.